Welcome to the deep dive. Today we're tackling something surprisingly common, chronic venous disorders, or CVD. Things like varicose veins, and sometimes, more seriously, leg ulcers.
Yeah, it's pretty widespread, so stats are quite striking. Maybe a third of adults in Western countries are affected in some way.
A third. And those venous ulcers, they can hit up to 4% of folks over 65, so it's definitely not a minor issue.
Not at all. And while some might think varicose veins are just, cosmetic, they can signal deeper problems and really impact someone's quality of life.
Exactly. So for this deep dive, we've managed to get our hands on, well, basically the instruction manual for vascular surgeons, section 23 of Rutherford's Vascular Surgery and Endovascular Therapy. It's called Chronic Venous Disorders.
Ah, Rutherford's, the definitive text.
Pretty much. We're specifically looking at chapters 154 through 161. Now, obviously, this is written for surgeons detailing how to manage these conditions surgically, but we thought, let's unpack it.
Right. Think of it like understanding the blueprint. Even if surgery isn't something you're facing, knowing the thinking behind it, the why and how, helps make sense of other treatments too.
You got it. So we'll walk through the main surgical approaches for those surface veins, the great and small saphenous veins, and things like phlebectomy.
And we'll also cover non-surgical options, how surgeons tackle those tricky connecting veins, the perforators.
And what happens when the deep veins aren't working right, plus how blockages in the really big veins, the iliac and caval veins, are handled both with traditional surgery and the newer, minimally invasive stuff. Ready to get into the weeds?
Absolutely. Let's start at the surface.
Okay, chapter 154, Surgical Techniques for Superficial Veins. It kicks off by reminding us that varicose veins, well, they can get worse over time, right?
That's the natural course, yeah. It's progressive. And there's a whole spectrum of options, just watching and waiting, compression, maybe some meds.
Then more active stuff like sclerotherapy, injecting them.
Right. Or surgery.
And surgery itself has evolved. You've got the traditional open procedures and now the endovenous techniques working from inside the vein.
The choice really depends on the person, doesn't it? How bad it is, their health, their symptoms.
Exactly. And the chapter really hammers home the need for a thorough evaluation before any surgery. You need a precise map.
One thing that struck me was the marking. Surgeons have to mark the veins they're going to treat while the patient is standing up.
Oh yeah, absolutely crucial, especially for phlebectomy, removing the smaller ones or if they're going after specific perforators.
Because once you lie down and elevate the leg, those bulging veins can just, well, disappear. Right?
They flatten right out, makes them incredibly hard to find. It's all about targeting the right spots, the sources of the reflux.
Okay, let's talk great saphenous vein, the GSV, that long one on the inside of the leg. The chapter gets pretty detailed about the top end, where it joins the deep system, the saphenofemoral junction, or SFJ. And there can be quite a few tributaries joining right there. Up to 6, sometimes more, sometimes fewer. It's variable.
So the guide says surgeons need to dissect carefully around that junction, a bit above and below, to make sure they find all those little side branches that might be feeding the problem.
That dissection is key to interrupting all the reflex pathways. And if they're just tying off the top, ligation without stripping, they might need to dissect even further down the GSV to catch tributaries joining lower down.
And for that high ligation, they usually tie the main GSV stump twice, right near the femoral vein. And they mention this interesting step, folding the cut end of the GSV inwards.
Yeah, involution. The idea is it might reduce neovascularization, new problematic blood vessels forming there later, which can cause recurrence.
But here's where it gets interesting. The chapter brings up a study suggesting maybe tying off every single tributary at the junction isn't always best.
Right. There's evidence, like from Gina Assini's work, that maybe a more targeted approach only ligating the tributaries that are actually refluxing, shown on ultrasound, might actually lead to fewer recurrences long term.
That challenges the old tie-off-everything approach, doesn't it?
It does. It shows how techniques evolve based on research. It's not always just about removing things.
Fascinating. Okay, what about stripping? Removing the vein?
Still a standard procedure, though less common now. Usually they pass a flexible stripper device down the vein, often top down from the groin.
And the guide says going downwards helps detach side branches better and might protect the saphenous nerve.
Potentially, yes. The nerve runs close by. Once the stripper's through, they attach the vein to it and pull it back out, usually upwards towards the groin. Takes a vein with it.
Sounds like it could bleed a bit in that tunnel left behind.
It can, so they use techniques to minimize that. Tumescent anesthesia is a big one, injecting fluid to numb the area. Cushion tissues, and often it contains epinephrine to constrict vessels.
Makes sense. And the book also stresses leg elevation, before and during, and getting people walking soon after.
Early ambulation is key. Helps prevent clots and promotes healing.
Okay, moving to the back of the leg, the small saphenous vein, SSV. The guide really highlights understanding its connections behind the knee in the popliteal fossa.
Yeah, it can connect to gastrocnemius veins from the calf muscle or the intersaphenous vein. It's complex back there. If those connections aren't addressed, surgery might fail.
And the book notes that traditional open surgery might actually be good for tackling those complex junctions, especially if they drain right into the main popliteal vein.
It allows for direct visualization. The SSV surgery is typically done face down, prone, with the knee slightly bent. And again, duplex ultrasound marking beforehand is essential.
But stripping the SSV is generally avoided.
Generally, yeah. The sural nerve runs very close, especially lower down, high risk of injury.
So what do they do instead?
Often, they'll just excise a segment of the incompetent SSV and ligate any problematic perforators coming from the calf muscles nearby. It's more targeted because of that nerve risk.
Got it. Now, those smaller, lumpy veins, ambulatory phlebectomy.
Yep. Tiny incisions, maybe just a few millimeters, and they use special hooks to pull out those marked varicosities. Very effective for localized veins.
And for bigger areas, Travex.
Transilluminated powered phlebectomy. It's more advanced, uses tumescent fluid, a light under the skin to see the veins, and a powered device to basically break them up and suction them out.
Sounds pretty efficient for extensive disease.
It can be. Then you have the saphenous sparing approaches, which are really interesting. CHIVA and ASVEL.
CHIVA, that's the one aiming to redirect flow, right? Not just remove the vein.
Exactly. It stands for a long French name, but the principle is hemodynamic correction. You use detailed ultrasound mapping beforehand to find the specific leak points causing reflux. The goal is to strategically interrupt those points, often through small ligations, to encourage blood to flow correctly back into the deep system via healthy perforators. It's about restoring normal physiology.
Fixing the plumbing, like you said, not ripping it out.
Pretty much. There's even a classification system by Franceschi to help understand the different ways the superficial and deep systems connect, which guides the CHIVA strategy.
And the results. The book mentions a couple of trials.
Yeah, one randomized controlled trial by Carandina compared CHIVA to traditional high ligation and stripping, HLS. At 10 years, the CHIVA group actually had a lower recurrence rate.
Lower recurrence, that's significant.
It is. Then another big trial by Perez suggested a higher cure rate with CHIVA, but that one faced some criticism.
Why is that?
Well, the patients mostly had quite mild disease, maybe more cosmetic concerns, and the study didn't really capture patient-reported outcomes, how people actually felt, so some debate about how broadly applicable those findings are.
Okay. And as failed.
Ambulatory selective varices ablation, another saphenous-sparing technique mentioned briefly. The idea is similar. Treat the tributaries, preserve the main trunk if possible.
Now, we can't ignore endovenous ablation, EVA. The book flags this as the major, minimally invasive alternative to HLS.
Oh, absolutely. It's become dominant. Uses heat, like laser or radiofrequency, or sometimes non-thermal methods delivered via a catheter inside the vein to close it off. We won't dive deep into the EVA techniques themselves today, as that's chapter 155, but it's crucial context.
Huge shift then. So looking at the overall results.
Big picture, yeah. HLS used to be the mainstay, now EVA procedures far outnumber it. The stats show a dramatic decline in stripping and a massive rise in ablation.
But HLS still has value. The book mentions some key studies.
Definitely. The EJPHAR trial, for instance, it looked at patients with severe CVI, actual ulcers. Adding surgery HLS to medical therapy significantly reduced ulcer recurrence compared to medical therapy alone.
So for severe disease, surgery made a difference.
Yes. And another trial by Michaels looked at uncomplicated varicose veins. It found that HLS plus phlebectomies improved quality of life and symptoms more than just compression stockings alone.
Okay, and newer data.
Some registry data, like from the VQI, suggests that for patients with just visible varicose veins, C2 disease, doing ablation plus phlebectomy might lead to better symptom improvement than just ablation alone.
Right, tackling the tributaries too. What about patient management bits? Anesthesia.
Ranges from general or regional in a hospital to just tumescent local anesthesia in an office setting for many EVA procedures and phlebectomies. Depends on the procedure, resources, surgeon experience, patient preference.
And reimbursement varies by setting too, hospital versus office.
That's always a practical factor. And finally, the chapter notes that even with EVA being so prevalent, there are still specific situations where good old ligation and stripping might be indicated. It's not obsolete.
Good overview. Okay, let's shift to Chapter 157, non-operative treatment. Crucial stuff.
Absolutely, because for many people, this is the starting point or even the main treatment.
It reminds us again how common CDD is and the economic hit healthcare costs, lost work time.
And it's likely increasing as the population ages.
So the cornerstone of non-op treatment, compression therapy,
Right. Lots of types. Gradient elastic stockings are the most common.
the ones you get measured for.
Exactly. Different compression levels, class 1, 2, 3, different lengths. Fit is key based on circumference measurements, and they wear out, need replacing every 6 to 9 months usually.
Does compression actually prevent varicose veins if you start early?
The evidence there is a bit shaky, honestly. For early stages, C1, C2, spider veins, or uncomplicated varicose veins, it seems to help with symptoms like aching or swelling if people wear them consistently. But it probably doesn't stop the underlying disease progressing or stop veins coming back after treatment.
So it manages symptoms, doesn't cure.
Pretty much. But for more advanced disease, C3 to C6, with swelling, skin changes, ulcers compression becomes vital.
Though getting people to actually wear them consistently can be tough, right?
Oh yeah, compliance is a huge issue. They can be hot, difficult to put on, especially for older people or those with arthritis. There are aids, stocking donors, but they aren't always covered.
And what about after a DVT, a blood clot? How long should you wear them to prevent post-thrombotic syndrome, PTS?
There's debate there too. The Oxytavia trial suggested 12 months might be as good as 24 months if patients are compliant. But other meta-analyses have questioned if stockings prevent PTS effectively at all, so the jury's still out a bit.
What about other compression types? Circade.
That's an inelastic device, often uses Velcro straps. Can be easier for some people to manage than strong stockings. One small trial suggested it might heal ulcers faster than elastic bandages.
And Una boots, layered bandages.
Yep. Uniboot is a paste gauze bandage, stays on for days. Layered systems provide high compression, good for ulcers. And then there's intermittent pneumatic compression, IPC machines with sleeves that inflate and deflate. Those pumps can be really helpful for stubborn swelling or ulcers.
Going back to the Eschar trial again, comparing surgery versus compression for ulcers.
Right, Chapter 157 notes that trial found no big difference in ulcer healing rates at 3 years between surgery plus compression versus compression alone.
But recurrence is lower with surgery.
Yes, significantly lower recurrence in the surgery group, especially for certain reflux patterns. And another long-term trial follow-up by Van Kent also found surgery treating superficial and perforator veins was better than just compression for staying ulcer-free and preventing recurrence, even though they didn't see a difference in quality of life scores.
Interesting. So objective healing versus how people feel isn't always aligned.
It happens. Quality of life is complex.
Okay, briefly on medications.
The chapter mentions several. Diuretics, zinc, things to break down clots, pentoxifylline for ulcer healing, but the main focus is on phlebetropic agents, especially MPFF.
MPF.
A micronized, purified flavonoid fraction. It's a plant-based compound. The chapter highlights it has strong level 1A evidence for helping with symptoms like pain and swelling in early CVD.
So it actually works for symptoms.
Good evidence suggests it does. And it might also be a useful add-on treatment to aid ulcer healing in severe C6 disease, alongside compression and other measures.
So compression and MPFF seem like the main non-op players, and maybe genetic therapies in the future.
That's the hope mentioned. Okay, ready for perforators, Chapter 158.
Let's do it. Perforating vein inconfidence. These are the connectors, right?
Exactly. Linking superficial veins near the skin to the deep veins in the muscles. When their valves fail incompetence, blood flows the wrong way outwards, adding to the problem.
And this is common in CVD.
Very common, often seen alongside reflux in the main superficial veins, like the GSV. There's this overload theory. The high pressure from superficial reflux might damage the perforators over time.
But fixing the superficial reflux might fix the perforator reflex too.
Often, yes. The outward flow in the perforator might start once the main superficial highway isn't overloaded anymore, but the valve itself might not become fully competent again.
And how many times the chapter classifies them?
Yeah, direct or indirect connections, and by location, foot, ankle, calf, etc. Clinically, the important ones are often the medial calf perforators, cockets, boids, and some on the outer side too. And crucially, they run alongside arteries and nerves.
You need to be careful there, especially with injections.
Definitely. Diagnosis involves feeling for defects if they're large, but mainly duplex ultrasound. It can show that outward flow for more than half a second, or if the veins dilated over 3.5 millimeter. Finding them near ulcers is key.
So if you have skin changes or an ulcer and refluxing superficial veins leading that way, plus these bad perforators.
The recommendation is usually to treat the superficial reflux first. You can treat the perforators at the same time, or maybe stage it, fix the superficial veins, wait and see if the perforator reflux resolves on its own.
Makes sense. How are they treated? Open surgery.
Used to be more common. SEPS, subfascial endoscopic perforator surgery, uses a camera. But they're more invasive, higher complication risk, so less routine now.
What kind of complications?
Clots, vein inflammation, nerve pain. Registry data showed decent ulcer healing with SEPS, but also these risks. Long-term studies showed SEPS beat conservative treatment, but a Cochrane review was less conclusive about its overall benefits, especially on recurrence or combined with other surgeries. Plus, SEPS can sometimes miss perforators.
So less invasive options became popular.
Exactly. PAPS, percutaneous ablation of perforating veins, done through the skin, often in office.
How does a PAPS work?
Two main ways. Thermal ablation, usually laser, using a fiber guided by ultrasound inside the perforator.
Inject tumescent fluid, then zap it.
Pretty much. Or ultrasound-guided sclerotherapy, injecting a chemical sclerosant to close it off.
How well does sclerotherapy work for these?
Decent occlusion rates reported, but potential for skin issues, even DVT. And being on blood thinners might make it less effective. Interestingly, what predicts success might differ. Size might matter more for sclerotherapy failure, whereas pulsatile flow might be bad for laser success.
Okay, and after PAPS?
Check the deep veins right away for clots, compression dressing, follow-up ultrasound within a week usually, to check closure and for any DVT.
Right. Moving deeper now. Chapter 159, deep venous incompetence. Valves in the main pipes aren't working.
Exactly. The femoral, popliteal, tibial veins, the deep system carrying most blood back. Failure here means significant backward flow.
What causes it?
Can be congenital, but usually it's primary floppy valve cusps, or the vein wall itself dilates, pulling the cusps apart, or secondary after a DVT damages the valves. And again, long-term superficial reflux might contribute to deep incompetence over time, but fixing superficial might help the deep sometimes.
Yes, that possibility exists. It highlights the interconnectedness.
Diagnosis starts with history, exam, checking pulses, especially with ulcers. History of DVT is a big red flag. Then complete venous duplex ultrasound is key.
What does duplex show?
It can visualize the valve cusps moving in primary incompetence. It quantifies reflex reversed flow for 1 second in femoropopliteal veins, 0.5 seconds in deep femoral or tibial, and it can suggest obstruction.
What about venography? Injecting dye?
Descending venography used to be the gold standard for looking at valve structure and reflux severity, but it's invasive, has limitations. Duplex provides functional info, venography more anatomical. Together they give a good picture, but the ultimate view is often at surgery.
And CT or MRI?
More for looking for blockages or external compression. The CEAP classification helps guide how extensive the workup needs to be.
Okay, surgery for deep vein valves. Sounds complex.
It is, usually reserved for severe symptoms not responding to conservative treatment perioperatively. Antibiotics, often heparin during surgery, general anesthesia. Needs specific surgical exposures to get to the femoral or popliteal veins.
And how do they actually fix the valve?
Several techniques. Internal valvuloplasty is common. Kistner, Raju, others. Basically involves opening the vein, carefully placing stitches in the elongated valve cusps to shorten them, tighten them up so they co-opt, they close properly. Often just a 20% plication, a small tuck is enough.
Wow. Are there external fixes too?
Yes. External banding or application, trying to narrow the vein from the outside over the valve to help the leaflets meet. Less common now, perhaps.
Other options?
Valve transposition, if there's one bad valve but a nearby deep vein branch has a good valve, you can reroute the flow through the good one. Valve transplantation, using a segment of vein with a healthy valve, maybe from the arm or the saphenous vein, to replace the diseased segment. Even substitute or neovalves have been developed.
Definitely advanced reconstruction. How are the outcomes? Complications?
Major systemic complications are rare. Local issues like hematoma, seroma are more common. Wound infection, DVT can happen. DVT risk is higher if repairing post-thrombotic veins, but perioperative patency and valve competency are usually very good.
Yeah, long-term.
Studies on internal valvuloplasty show maybe 60–70% of valves are still competent at 5 years, which usually translates to significant clinical improvement for the patient. Results for other techniques are also reported. Follow-up involves clinical checks and duplex scans. It's impressive that these intricate repairs can be done.
Truly is. Okay, final stretch, chapters 160 and 161. Iliocaval venous obstruction. Blockages in the big veins draining the legs and pelvis. Chapter 160 is surgical treatment.
And it starts by saying, look, historically this was surgical territory, bypass grafts, but now endovascular treatment, stenting, is the primary approach for benign, non-cancerous blockages. Surgery is mostly for backup.
When stenting fails or isn't suitable.
Exactly. Causes are often prior DVT or external compression, like May-Thurner syndrome, usual thorough workup before considering surgery.
What kind of grafts do they use for bypass?
Autologous vein, like the saphenous, is preferred if available and suitable. But prosthetic grafts, like EPTFE, are often used, sometimes with external rings for support.
And they sometimes create that AV fistula downstream.
Yes, an arteriovenous fistula distal to the graft, especially with prosthetic grafts going to the femoral vein or longer iliocabal grafts. The high flow is thought to help keep the graft open, usually temporary, maybe 6 weeks or so. Needs careful anticoagulation management, too.
What are the main surgical procedures?
The classic is the cross-pubic bypass, the Palma procedure. Uses the saphenous vein from the other leg, tunnels it across to bypass a one-sided iliac blockage. Or iliocaval bypass using grafts to bypass blockages higher up, even into the vena cava.
Requires some major surgical exposure, I imagine.
Oh, yes. Retroperitoneal approaches, usually. That chapter details the techniques, graft sizes. Results from series showed decent patency, maybe 70–85%, and clinical improvement, though follow-up varies. Husney's series suggested the AVF helped improve results.
And for May-Thurner, the iliac compression. Surgery is backup here, too.
Yes, stenting is first line. If surgery is needed, it's often the Palma procedure again, or sometimes other techniques like mobilizing the artery, patching the vein, even moving the artery, though that's complex.
Okay. The chapter also briefly touches on reconstructing the vena cava above the kidneys and pelvic congestion syndrome.
Right, pelvic pain from varicose veins in the pelvis. Diagnosed with imaging, treated medically, or often with embolization, blocking off those veins minimally invasively.
Which leads perfectly into chapter 161, endovascular treatment of iliocaval obstruction, the current standard.
Absolutely. This chapter highlights the huge paradigm shift. Percutaneous stenting is now the go-to. It's made bypass surgery almost obsolete for benign disease and really expanded who can be treated because it's generally safer and very effective.
And it can help even if there's reflux, too.
Yeah, interestingly, treating the obstruction with a stent can lead to significant clinical improvement even if underlying reflux isn't directly tackled. And it might even help associated lymphatic dysfunction in some patients.
Who gets stented? Not everyone with a blockage.
No, definitely not silent lesions. CVD isn't usually lethal. Initial treatment for symptomatic blockage is often still compression. But stenting is great for those who fail compression or can't tolerate it, elderly, obese patients, those with recurrent cellulitis. Also used after dissolving acute iliac clots sometimes.
Diagnosis venography isn't enough.
It's often misleading, according to the chapter. Single plane views can miss significant narrowing, especially compression. They strongly advocate for IVUS intravascular ultrasound guidance during stenting.
Why IVUS?
Blinded comparisons showed venography consistently underestimates stenosis severity and misjudges where the disease starts and ends. IVUS gives a precise view from inside the vessel, essential for choosing the right stent size and landing zones.
So the technique involves IVUS.
Usually, yes. Get venous access, cross the lesion with a wire, predilate with large, high-pressure balloons, 16–18 millimeter often needed. Angioplasty alone rarely works due to elastic recoil. Then deploy large caliber stents matched to the normal vein size using IVUS. Undersizing is a major cause of failure.
Cover the whole disease segment.
Yes, absolutely crucial. Need disease-free landing zones proximally and distally. Better to stent liberally than too short. For post-thrombotic disease, the stent often needs to extend below the inguinal ligament into the common femoral vein, but ideally stop before the deep femoral vein orifice.
What about near the top where the iliacs join the IVC?
That confluence is a common spot for inadequate treatment, especially without IVUS. Often need to extend the stent a few centimeters into the IVC to cover spiral lesions properly. Wool stents, maybe 18–20 millimeters, are commonly used. Sometimes a proximal Z-stent is added for more radial strength.
Anticoagulation afterwards.
Varies. Often aspirin for non-thrombotic lesions. Longer anticoagulation, maybe warfarin or a DOAC for patients with clotting disorders, previous clots, extensive stenting, or after recanalizing a chronic occlusion.
And the results are good.
Technical success with IVUS guidance is very high, over 95%. Symptom relief usually follows hemodynamic improvement. Late occlusions after 30 days are rare in non-thrombotic disease, maybe 2% overall, more common in post-thrombotic cases.
What if symptoms come back? Chronic stent malfunction?
Usually due to inflow or outflow problems, missed disease at the ends, or new disease developing, or issues with the stent itself, inadequate initial coverage, migration, foreshortening. Incomplete coverage at the confluence is a frequent culprit, especially if IVUS wasn't used optimally.
Patency rates.
Excellent in non-thrombotic iliac lesions, NIVL. Naeglin's data showed around 79% primary patency at 6 years for NAVIL, but 100% secondary patency, meaning they could be fixed if they failed. For post-thrombotic PTS lesions, it was lower 57% primary, but still good secondary patency at 86%.
So even if they block, they can often be reopened?
Often, yes. The chapter also mentions benefits for specific groups like the elderly and obese, and even treating thrombosed IVC filters with recanalization and stenting.
Wow. That's a comprehensive journey through Rutherford's Guide to Surgical and Endovascular Management.
It really covers the spectrum.
So wrapping up this deep dive, the big story seems to be this incredible evolution, right? From mainly open surgery towards these much less invasive techniques.
Definitely. Endovenous ablation for superficial veins and especially ileocaval stenting have transformed treatment for so many people.
But open surgery still has its specific important roles. And across the board, accurate diagnosis using duplex and particularly IVUS for the deep stuff is just paramount.
Couldn't agree more. Precision in diagnosis leads to precision in treatment. These advancements have really improved outcomes.
Which leaves us with a final thought for you, the listener. With endovascular techniques advancing so rapidly, what's next? Especially for the really complex venous problems. How will innovation continue to shape things, and what's the right balance between going minimally invasive versus needing those bigger open reconstructions sometimes?
It's a dynamic field. The balance is always shifting based on technology and evidence. It's fascinating to watch.
Absolutely. If you are experiencing symptoms that sound like anything we've discussed today, please do talk to a vascular specialist, get a proper evaluation, and a personalized plan. And if you really want to dive deeper, well, Rutherford's awaits. Thanks for joining us.